If you're discussing the possibility of undergoing cytoreductive surgery for peritoneal mesothelioma, your surgeon will let you know that the goal is achieving complete cytoreduction. That term refers to removing all visible tumor material or reducing it to tiny residual nodules. This might sound like surgical perfectionism, but it's actually the single most important factor determining whether surgery is going to help you. The difference in survival between complete and incomplete cytoreduction is measured in years, not months. Today, I want to explain exactly what complete cytoreduction means, how it's measured, why it matters so much, and what happens if your surgeon can't achieve it. I'm Terri Oppenheimer. I've been writing about mesothelioma and asbestos for the website mesothelioma.net for over a decade. I'm not a physician, and this is not medical advice, but understanding complete cytoreduction helps you evaluate surgical success and helps you set realistic expectations. So let's start with how the completeness of cytoreduction is classified. Surgeons use the Completeness of Cytoreduction Score, or CC score, which categorizes residual disease at the end of surgery. CC 0 means there's no visible residual disease. The surgeon removed all visible tumor and there's no macroscopic disease remaining. This doesn't mean every single cancer cell is gone. Microscopic disease almost certainly remains, but there's nothing visible to the naked eye left behind. CC1 means residual tumor nodules that are less than 2.5 millimeters. The surgeon removed all tumors larger than 2.5 millimeters, but tiny nodules, smaller than a grain of rice, remain on the peritoneal surfaces. CC2 means tumors left behind measure between 2.5 millimeters and 2.5 centimeters. For reference, that means those nodules are larger than a grain of rice, but measure smaller than an inch. CC3 means the residual tumor material is larger than 2.5 centimeters, over an inch, or is so spread out that the surgeon couldn't remove it. Complete cytoreduction is defined as either CC0 or CC1. Incomplete cytoreduction is CC2 or CC3. These might seem like arbitrary categories. Does the difference between 2 millimeters and 3 millimeters of residual disease really matter so much? Research consistently shows that yes, that tiny difference can make a dramatic difference in outcomes. Let's look at the survival data. Multiple studies from experienced centers show the same pattern. Patients achieving CC0 or CC1 have 5-year survival rates of 50 to 75%. Their median survival is often 4 to 5 years or longer. Patients with CC2 have a median survival of roughly 12 to 24 months. 5-year survival drops to 10 to 20%. Patients with CC3 have a median survival that's often under 12 months. That's no better than what's derived from chemotherapy alone without surgery. Now, before I go on, I want to take a break here and ask you a quick favor. If you find these videos helpful, please hit the like and subscribe buttons below. It makes it easier for other people who need this information to find us. Also, if you have questions or there's a topic you'd like to see addressed in a future video, send me a note in the comments section. And make sure you watch until the end, because I'm going to give you valuable information on where to find resources that will make a real difference for you. Getting back to grading for cytoreduction, the difference between CC0 or 1 and CC2 or 3 is the difference between potentially living for years versus living for months. That's why complete cytoreduction is so critical. Without it, the surgery does not provide a meaningful benefit. Why does completeness of cytoreduction matter so much? The less residual disease burden a patient has, the more effectively HIPEC can reach and kill remaining cancer cells. HIPEC penetrates 3 to 5 millimeters into tissue. If residual nodules are 2 millimeters or less, HIPEC can potentially kill them. But if the masses are 2 centimeters, HIPEC only affects the surface while the viable tumor remains in the center. Smaller residual disease means the immune system and chemotherapy can better control any remaining disease. Larger residual tumors overwhelm these defenses. Tumor biology matters to surgical decisions too. Achieving complete cytoreduction often correlates with patients having favorable tumor biology. That means having the epithelioid cell type, which is a less aggressive disease. Inability to achieve complete cytoreduction sometimes reflects aggressive cell biology or extensive spread, which indicates a poor prognosis, regardless of how much tumor material after the surgery removes that the surgery removes. How do surgeons maximize the chances of complete cytoreduction? The biggest factor is meticulous patient selection. This means only operating on patients whose disease extent and distribution make complete cytoreduction appear to be achievable based on imaging and sometimes on diagnostic laparoscopy. Experienced surgical technique matters too. Peritoneal surface malignancy surgery requires specialized skills. Surgeons have to know which peritoneal regions can be stripped and which carry unacceptable risk, how to remove tumor material from organ surfaces without damaging the organs, when to remove organs versus preserving them, and how to recognize when complete cytoreduction isn't achievable and abort the operation. Adequate operative time is essential. Rushing through cytoreduction increases the chances of leaving residual disease behind. These operations often take 8 to 12 hours for thorough disease removal. What happens during surgery when complete cytoreduction isn't achievable? Sometimes the surgeon will discover that the patient's disease is more extensive than was suggested by the imaging. Unfortunately, imaging frequently underestimates the actual disease burden. If the surgeon finds that complete cytoreduction isn't possible, if the PCI is higher than expected, if the disease involves critical structures that can't be resected, or the tumor biology appears to be too aggressive, they face a difficult decision. Some surgeons will complete the planned cytoreduction and HIPEC, even knowing that CC0 or 1 won't be achieved, but hoping that partial debulking plus HIPEC will provide some benefit. Evidence for this type of benefit with incomplete cytoreduction is weak, but this approach is still taken sometimes. Other surgeons will abort the operation, closing the abdomen without completing the surgery if complete cytoreduction isn't achievable. The rationale is that subjecting patients to full cytoreductive surgery and HIPEC without achieving complete cytoreduction provides no survival benefit while causing significant morbidity. Which approach is better is being debated constantly. Conservative surgeons favor aborting operations when complete cytoreduction isn't achievable. More aggressive surgeons complete the operation, hoping for some benefit. This is exactly why some patients undergo laparotomy, which is opening the abdomen without having full cytoreductive surgery. The surgeon can look inside, determine whether complete cytoreduction is possible, and if it isn't, then close without completing the operation. While that's disappointing, recognizing when surgery won't help and sparing the patient the physical trauma of a futile major operation actually reflects good surgical judgment. What affects whether complete cytoreduction is achievable? Disease extent measured by PCI is primary. A lower PCI correlates with higher complete cytoreduction rates. Disease distribution matters. The involvement of certain critical areas prevents complete cytoreduction, even with moderate PCI. Cell type influences biology. Epithelioid disease is more likely to be completely resectable than the sarcomatoid type. The surgeon's experience affects outcome, with high-volume surgeons at specialized centers achieving complete cytoreduction more often than surgeons who occasionally perform the surgery. It's because they've refined both their techniques and their patient selection. What if you undergo cytoreduction and it's incomplete? If your final pathology report states CC2 or CC3, this does not mean the surgery was a failure or mistake. The surgeon made their best effort and circumstances prevented a complete resection. Your prognosis is less favorable than if CC0 or 1 had been achieved, but you might still benefit from the debulking and the HIPEC you received. Just keep in mind that postoperative systemic chemotherapy becomes even more important when residual disease remains. Some patients with CC2 status live for years with good disease control from a combination of surgery, HIPEC, and subsequent chemotherapy. But statistically, outcomes are much better with complete cytoreduction. Should you ask your surgeon about their complete cytoreduction rate? Absolutely. At experienced centers, complete cytoreduction should be achieved in 70 to 90% of patients taken to surgery for peritoneal mesothelioma. If a center's complete cytoreduction rate is much lower, say 50%, this suggests either subpar patient selection leading to operating on patients who shouldn't have surgery or inadequate surgical technique. Ask the surgeon what percentage of their peritoneal mesothelioma patients achieve CC0 or CC1. Ask what their threshold is for aborting the operation if complete cytoreduction doesn't appear achievable. And what happens if it turns out that you can't achieve complete cytoreduction in my case? To review, complete cytoreduction means that after the surgery, there's no visible disease or that residual nodules are less than 2.5 millimeters. This is critical for peritoneal mesothelioma surgery success, giving patients the best chance of achieving a 50 to 75% chance of 5-year survival versus 10 to 20% with incomplete cytoreduction. The difference between the two is years versus months of survival. Complete cytoreduction is achieved through meticulous patient selection, experienced surgical technique, and adequate operative time, all of which allow HIPEC to effectively target microscopic residual disease. Experienced centers achieve complete cytoreduction in 70 to 90% of patients. If complete cytoreduction isn't achievable during surgery, some surgeons will abort the operation to avoid putting the patient at risk of complications. Be sure to ask any surgeon you're considering working with about their complete cytoreduction rates. You can visit mesothelioma.net for more information about cytoreductive surgery and peritoneal mesothelioma, or call 1-800-692-8608 or use the live chat feature on our website to speak to one of our patient advocates right away. As for me, remember to post questions below, and I'll see you next time.